Okay, well, welcome everybody to this open house on Mantra's collaborative telemental health model. My name is Ed Gosson. I'm the co-founder and CEO of Mantra Health. Really excited to be here today. The goal for our conversation is to have an extremely open dialogue. Any questions that you have, feel free to ask, and we are kind enough today to be joined by Dr. Dawn LaFrance, who is the Counseling Center Director at Colgate University, and Dr. Nora Felpouch, who is the Medical Director for Mantra Health's provider group. So before we get started, maybe I'll ask Dawn if you want to start by introducing yourself, and then we can go to Nora.
Yeah, sure. Thanks, Ed. I'm Dawn LaFrance. My pronouns are she, her, hers, and I have worked at Colgate for more than 20 years. My current title is Assistant Vice President for Counseling and Psychological Services. So I oversee the Counseling Center and Haven, which is our Sexual Violence Resource Center, as well as the Shaw Wellness Institute, which is more of a sort of preventative programming department on campus. And I work really closely with Student Health Services. And this is one of the areas that we have sort of combined efforts to make sure is running really smoothly for our campus. So I'm happy to be here. Thanks for the invitation.
Thank you, Dawn. Nora?
Yeah, I'm Nora Felpouch, also she, her, hers pronouns. I really started in college mental health all the way back in residency, actually, at Michigan State University at their counseling and psychological services program. I was there for a couple of years, then moved out to Colorado, worked with Colorado State to build an interdisciplinary team to address high risk and post-hospitalization care on campus. And that's when I first got involved with Mantra. They were reaching out really to clinicians with expertise in college mental health generally as they were designing this program, and really have built it from the ground up that way. And so I started to get involved then and really fell in love with the model and with the enthusiasm and the mission of the company. So I joined as the medical director just sort of 2 years ago. And we've really worked to build a provider group. I also have worked back with Michigan State again, putting telehealth together in CAPS and helping them get that started and up off the ground. And then I also maintain somewhat of a national presence in college mental health, working with the Association for College Psychiatry. So yeah, delighted to be here. And Dawn, so excited to have you here as well.
Thank you so much, both. So as both Nora and Dawn mentioned, the topic that we're going to be talking about today is really about how campuses can think about how to integrate with telehealth partners. As we move into a world where students are both coming to the counseling center, but also maybe online, and where you may need support for some of the overflow that you're seeing at the counseling center, or students that are maybe not coming because of stigma. I think there's been a lot of conversations about how to work with hybrid models and how to integrate telehealth on campus. And so, as I said, this is really an open forum. We have a bit of an agenda for the first 30 minutes. We're going to ask a few questions to Dawn about our current experience with Mantra Health, and go into some of the data of our partnership, go into some of the questions that we also received ahead of time. So thanks for submitting some of those. So we'll cover those. And then finally, we can talk about our collaboration portal a little bit, which is really key to how we've set up our model. So I can walk everybody through a bit of a demo. And as we go through this, please use the Q&A box throughout the webinar, and then we can cover the questions towards the tail end, and have the ability to move people up into the conversation. So we'll do that and really try to make this interactive. So we'll get started with a few questions for Dawn, and maybe the first one being, what were some of the reasons that Colgate decided to expand their clinical team, including a telehealth provider like Mantra? And what were some of the gaps you were trying to fill at the time?
Mm-hmm. Yeah, thanks for the question. So when we decided to sign on with Mantra, we were actually in a pinch as far as our psychiatric care. So we had formerly had a staff member at the Student Health Center that was a psychiatric nurse practitioner who we worked really closely with. And She would come up to the counseling center, see people in person, and we had a consulting psychiatrist from the local area that would spend 3 to 4 hours on campus with her. So work really closely with her, and then see a couple students, and then sort of transfer the care to her. Well, she retired, unfortunately for everybody, and moved on to hopefully bigger and better. And we were sort of left with trying to figure out what to do. We did find another psychiatrist, who was willing to work with us through COVID, because the other thing that we ran into is the local psychiatrist didn't want to come on campus during COVID. So we had to find somebody who was willing to do telepsychiatry. So we found somebody about an hour away who just did telepsychiatry for us, but only for a semester. It was just a part-time thing for her to do. And then she was unable to continue. So we're kind of in this place of not having the psychiatric needs met that we had, and students and the campus were used to having that as an available resource. So we did some research. We relied on some really good partnerships in the higher ed world to collaborate with us and talk us through some things, and decided to go with Mantra because it seemed like the business that was most receptive to what our needs were at the time. And I think that we've been really lucky with the way that things have developed since then. So it was really to fill a need. And at the same time, we do have medical doctor on staff who's really wonderful and is able to prescribe a number of psychiatric medications, but she can't devote her whole caseload to psychiatry. So we've been really happy with where we've been able to move since then, but it was really to fill a gap and a need that we had been able to fill before.
Yeah, and we know there's hundreds of rural colleges across the country that are in a very, very similar situation, and many of them are located in a psychiatry desert where referring to the community is just a lot of the time not really an option. Students often don't go to these appointments, and finding a provider to come, not on a full-time basis on campus can be really hard. So I guess as you were going through your evaluations, and as we sort of built the relationships in the early days with yourself, with Dr. Miller, can you talk about I guess like some of the criteria that you use to evaluate Mantra as a potential partner, and then what recommendations do you have for schools that may be in the same position, that may be looking at a range of different partners, and what are the things that schools should think about when making a decision?
Yeah, I think that schools should think about, and what we thought about is what we really needed. So we had considered using some telecounseling before, but with a different company, and as we looked at that, our students really didn't want that. They wanted to see us in person whenever possible at the time. So when we were looking for what became Mantra for us, is we're just looking for psychiatry, and a lot of companies, you need to invest in both, and we didn't need both at the time. So that was one thing that was important to us, is just figure out what our need is. I think it's important to figure out how many hours that need is, and what's a need and what's a want on your particular campus. I think that can be different things. And then the budgetary concerns that go along with that. So the price cost that you're willing to go to, sort of thinking through those things, so that you have your limits in place too. So as far as what really helped me make the decision, along with Dr. Larson, who I'm working closely with on this, is the receptivity of your company. I feel like people call back quickly. The customer care is really good. You have your product that you launched and have been using, but it's changed along the way, depending on feedback that you've received from us and from other schools. So I really appreciate that. I appreciate that there's been several Zoom calls, even through COVID, to figure out what we like most, what we would love changed if we could. And there's always been some indication of interest of meeting us where we are. So every school is a little bit different, but I think really defining what your needs are and figuring out what company can best suit those needs, along with the budgetary constraints, are sort of the first two things that I would recommend looking at.
Thank you.
Mm-hmm.
So maybe going into some additional questions, Nora, is there anything you'd like to dig into here with Dr. LaFrance on the clinical front to help with?
Yeah, I think I have just a couple of comments that you had mentioned, Dr. Larson, who's a primary care provider, who's actually pretty skilled in handling these kinds of cases. But even she was getting to the kind of the edge of her knowledge and her comfort level. I think a lot of these cases that are coming into college mental health now are quite complicated. And sometimes having a second set of eyes or having someone who really specializes in psychiatry can be really incredibly helpful, even when it's only a small number of cases. I think the other thing is that as we build Mantra, we know that we are the face of your school. And so I think that's really important too, is that kind of one of the reasons we collaborate as much as we do is in part because it's good for care, but in part also because we understand that even though we think we're separate and we're Mantra, and you might think we're separate, to the students, we're the same. And so if they have an experience that isn't optimal with us, that reflects back on your counseling center. And the same thing with, if we have a high risk case or we have something where we need to go back and partner together to make sure that every piece of that was attended to appropriately, you want to be reassured that whoever's doing that has the team in place and has the ethic in place to make sure that they are representing you to students in the way that you would want to be represented. And I think that's one of the reasons why we built such a collaborative program, is that we don't think of ourselves as a separate box that you can kind of dump students into and lose. Instead, we think of ourselves as a collaborative model. It was really built that way.
Mm-hmm.
Yeah. And perhaps, Nora, one thing to also talk about in the care philosophy, which I think is quite unique to our approach, is sort of the interventions when it comes to high-risk students on campus.
Yeah.
I know this is something that we've thought a lot about in the early days, and one of the key reasons why we brought you in is because we think that integrating with on-campus resources when it comes to these types of interventions is crucial. So can you maybe elaborate a little bit on the work that we're doing on that side of the house, and anything that obviously, Dawn, you're willing to also share in terms of where we've been able to help?
Yeah, absolutely. So this is critical, right? We know that suicide, second leading cause of death in this population. High risk definitely comes up. And we want to make sure that our providers are really well equipped to handle that, but also know exactly how to integrate into the campus services if they exist on the ground. We certainly work with schools that don't have campus services, but we want to know that ahead of time. And we want to make sure that everybody's on the same page and has created a plan ahead of time for when these high-risk cases come up. We actually have a clinical team that stands by, that's ready to hop in and help. And we're able, and this was actually a project that we started with Cornell on a suggestion from Cornell that now has been expanded across our whole network. And that is that the providers can actually hit an emergency button when they're talking with a student, if their risk is escalating to the point where the provider needs support. And then one of our really experienced clinicians, either myself, the executive director of therapy, we can actually step into the call if we need to. So it's almost like having a colleague sitting there who's an expert in suicide assessment and these sorts of things, who can not only advise the clinician in real time, but can step in and talk with a student if necessary. And then we'll talk a little bit later about kind of how we integrate into a school. But one of the things we pay a lot of attention to is, what do your resources look like on the ground? If a student is in crisis, where are they? How do we handle that? And really make sure that that is tailored very specifically, because we would not want a student in a telehealth to be treated in a different way than they would have had they walked into the counseling center. That's really important to us, that equity of care, that we are matching at least that level of on the ground. So we don't have a student that happens to pick one service over another and ends up, losing their life as a result of that.
Yeah.
Yep. So along those lines, we each school has sort of a Mantra care representative, and we review those protocols at different points in the year to make sure that we're on board with what should we do in an emergency, who should we call, what's your on-call system, do you use protocol, do you use something else, so that they have that all in their database too, which I think is really helpful. And I appreciate that as we change, we can update that pretty easily. I also really like the portal that we use to communicate, so that we can have those confidential communications, and you can add whoever you want on your team to your side of the portal. So let's say that one of the Mantra providers, Carla, is seeing somebody in telepsychiatry, and I want to be informed of different things, along with Dr. Larson and maybe an adjunct counselor who is seeing that student too. We can all be tagged in the communications, And then in our email, we get a little line that says, please check your Mantra portal, which we can easily log into and kind of see. So recently we had a pretty complicated case, somebody who had a lot of different symptoms, trying to rule out different kinds of things and maybe approaching different diagnoses, kind of figuring out how we can help the student the best. And everybody kind of comes into it with different perspectives, but we were pinging each other quite a bit over the course of 2 days just to kind of wrap our head around how to support this one student. And make sure that if the student was complying or not complying, we were all sort of aware of that. So I really appreciated the level of communication, and it's also not too high on the other end. So that student was a particularly tricky case that I think all of us really wanted to wrap our heads around together. But there's other cases that are real straightforward and simple. They get into the portal, they meet with one of the providers, and we have decided to upload all of the Mantra intakes into our EHR here. So we do that step, or we have an office manager do that step. And then we don't really have much follow-up with Mantra because it's a pretty easy case. Let's say that they're on an SSRI and they're just going to continue to do that. We might make sure that they're complying with those things, but there's a low level of communication when it's not necessary. And I think that's really important to say too, as far as from all of our busy lives, like being able to triage and work effectively together, but not over communicate or under communicate.
Yeah. Mm-hmm. Mm-hmm. The system's actually designed for that. So you can set within the system how much communication you want, and then you can change that on a particular student if something comes up that you really need to collaborate or coordinate on. For sure, I think that collaboration piece is so important. Someone had asked, I think it was Carrie, had asked about, how do we manage the releases and things like that. Those are all done ahead of time. So as the student logs in and creates their portal account, then we can sign those releases, or they can sign them on the ground with whoever's referring them. So we do create this sort of collaborative system where each different person can have a different level of access based on what they need. So we have some schools that want to see sort of an overview, what number of students are coming through, what are their numbers looking like, what kind of diagnoses are we seeing, so they can see that from a bird's eye view. Or if they're a clinician who's actually working with one of our providers, they can see that from actually getting to the chart and seeing the notes. And that's something, as we designed the system and as we train providers, as we hire and train providers, we really do a deep dive into clinical note taking and making sure that they are creating notes that are very thorough, that have a good sense of their assessment and plan. We look at those very closely so that you can look at that and get a quick understanding of what's going on clinically in their mind, which I think is really important when you're collaborating, is that the communication itself is tweaked in a way that makes it efficient.
Yeah.
I touched for just a minute on adjuncts. We do have 3 adjuncts in our office that work. One person only works 1 day and another adjunct works 3 days. So they're not part of our sort of crisis system, but they may be referring to Mantra. So in that case, we add their supervisor to that collaboration portal so that the supervisor can see stuff when the adjunct is not here. Similarly, for schools who have trainees, I think that's an important feature too, so that whoever the supervisor is and whoever's the full-time staff member that's here all the time is aware if the clinician in Mantra is seeing something that needs attention soon. So.
Don, one question I want to ask you is, we're, I think at this point about almost 2 years into our collaboration. It's been great. How would you summarize the impact that I guess Mantra has been able to have on your campus? And we'll walk through some of the outcomes after this, but from your own words, very curious to kind of hear how you would reflect on the last 2 years.
Yeah, I think that it's been a very successful partnership. I think the efficiency has really helped our staff here. It's a pretty easy process to get students connected to Mantra. And then we feel like once we do that, we can stay, like I said, connected as we need to for care moving forward, but there's not a lot of hoops and hurdles. In the past, one of the things that we needed to do in order to refer to our consulting psychiatrist was the preference really was to see a student for 2 to 3 times before we made the referral in. And we've really eliminated that with Mantra because the Mantra providers are willing to see students quicker. And that's been really helpful for us, especially the way I think that this current generation is kind of programmed to seek immediate attention. And I also don't feel like the mantra providers are pushing psychotropics on students either. They're kind of recommending other things like counseling, like group, and then saying this also might be helpful if you decide to do this. So I've never felt like anyone has been really pushed into taking something they're ambivalent about. And sometimes we do refer to mantra for those students who are on the fence, and we just want them to consider all of their treatment options. And this being one of those things that could help, but might not be necessary. And I've never felt like the mantra provider feels like put off by that in any way. They've been very open to seeing students sort of on that whole level of severity, which is really helpful for our system here, because we're seeing a lot of students at clinical and a lot of students at subclinical levels that find their way in the counseling center. And we're really trying to figure out what their needs are.
I'm glad to hear you say that, Dawn, because that's something we've done a hard push on too, and we're interacting with and supervising our nurse practitioners, is that idea that you're a diagnostician first, and then you develop a therapeutic relationship, and then you advise if it's appropriate to do medications. And I think that's one of the reasons Mantra also makes sure that we keep the amount of time that we need for appointments. We do hour-long intakes, we do half an hour follow-ups, and part of that is because we understand the clinical piece, that this is not just something where we can just, keep hitting the same nail with the same hammer over and over again if we really want outcomes to be the highest level of care.
Yeah.
Yeah.
Another thing that I just wanted to point out and not forget to share on this is the availability of hours has been really great on our end. So some providers are available for evenings and weekends, and given how busy our students are these days, that can be really helpful if they can do a telepsychiatry appointment in the evening if they have, I don't know, classes and sports all day or whatever they're involved in. So, so those hours of availability have been really helpful too.
Great. Well, without further ado, I'll share my screen and we can walk through some of our data. And obviously, Dawn, you've already seen these. You've walked through them with Kelly's team, but this gives a lens for the rest of the group here that's on the call today about kind of how we present outcomes to our partners. And Nora, maybe I'll follow your lead if you'd like to kind of like speak through the outcomes that we've had with Colgate over the last year.
Yeah, absolutely. So, and I think Colgate is certainly reflective of outcomes we've had generally. I think we've seen some pretty good trends, which are exciting to be part of. So we've seen about 78 total students who were referred since August of 2021, and we certainly have schools where there are more referrals than this, and some that are less, just depending on the size of the school. And just about a little shy of 3/4 attended an intake appointment. I think this is important to note that there are always these students who kind of fall through the cracks, but if a student gets referred to Mantra, we have a care navigation team that follows up on that. So we're really focused on not allowing students to fall through the cracks if they get referred, so you don't have to worry if you send them to us. Unlike it's something that we were trying to create as an extra value, that we knew that could be some trouble with telehealth and with students in general, and we really want to make sure that we have eyes on when those students are handed to us. They're ours, and we're going to hold them until we either get them to a higher level of care or a different level of care, or refer them out. So I think that's an important piece, that even though only 72% attended an intake appointment, that doesn't mean that the remainder just were lost. Is that we've worked to find an alternative for those students. So you can see, just like you see in any counseling center, there's some fluctuation over time, the number of students that are referred. So yeah, it looks like there are about 9 referrals per month. And Dawn can speak to this, but the referral process is super quick. It's something that we tried to make very easy to prevent any barriers to care.
Great.
Yes, the referral process, just in a nutshell, requires us to log into the portal, add some basic demographics, address, phone number, name of the student, and our clinical impressions. And what we want, really, what we're asking for. It might be some help with diagnostics. It might be considering medication, whatever that may be. There's a couple questions that are really easy to answer about drug and alcohol use or previous hospitalizations, but just a lot of just some checks. So literally, I would say you could devote about 5 minutes to being in there to have somebody referred in. Some clinicians do really appreciate if you can upload your intake that you did with a student. And I try to make that sort of best practice here just so that they can go in with some knowledge of what we've seen. But that's not required either. I haven't seen anybody that's required that. It's more of a
Yeah.
would appreciate it if possible. So I would say that, you know, at the end of the day, if I have somebody who I saw that day that wanted to be referred into mantra, I would take 5 minutes to get them in by the end of the day. So I know that's done by the time I go home in the evening. But really, really easy. And then if there's more questions from the mantra clinician after the intake, then they would be in touch with you to kind of clarify.
And then the schools that don't have counseling centers on the ground, we do have processes that look a little bit different for those schools to be able to refer students in as well.
Yeah, I'll touch on this towards the end, and that's a great addition. Yeah, maybe moving into some of the program time to care that we actually track as well.
Yeah, so we're trying to get students in, and remember that for Colgate, this is psychiatry too. So that's typically out in the community. You're talking 3 to 6 months if you have availability at all. And Colgate's in a relatively rural area, so getting access to any psychiatrist at all can be pretty challenging, as is true for many of our schools. But you'll see that during the really busy parts of the school year, we've got September, October, November. You're looking at under a week to get a student in with psychiatric care. And because we are so collaborative, we can also accommodate if there's a student who particularly needs to get in quickly. You can let us know that, and we can move some things around in order to be able to make that happen. You see the big bump, that's because it was over winter break. So they got referred before winter break. We will see those students. We will triage those students and then figure out, are they safe to wait till the end of winter break to get back in again? And so that's why there's a little bit of a delay there. This is something that our team communicates regularly with the schools team as well, so that you can see how long it's taking to get students in. If there's any hiccups or anything like that, we have a partner success team dedicated specifically to making sure that our time to care works well for students. So feedback, we look at a number of different things as far as feedback from students. We look at match with provider. We look at whether that student feels like it helped them to stay in school. And we'll show some numbers in a minute around that. But for Colgate specifically, 8 out of 10 match with providers. Again, because we're so collaborative, if there is a poor match, you can let us know that, and we can try to switch that student around to figure out what can be done there. Almost 91 and a little more than 0.5% said that the providers and I collaborate on goals for psychiatry. And I think this really speaks to not only the type of providers that we hire, but also our training, that we really do try to have a collaborative process with students, because we think that's important for the therapeutic relationship, which dictates a lot as far as outcomes. And then a little over 83% providers helping me accomplish my goals in psychiatry. Dawn, does that resonate with what you hear on the ground from Colgate students as far as how they feel about mantra?
Yeah, I do think so. And like the 83.33%, we get those kinds of numbers here about the counseling that we do too. We don't always find that the students necessarily employ what we're trying to help them employ. So that number being there, I think, is a really solid place to land on. How well do you think the match with your provider? This is, again, for Colgate, we have 3 providers assigned to us. So we would have a little bit of room. And this has happened at times where a student maybe doesn't necessarily feel the match, just like with a counselor. We do ask students, rather than not following up, to talk with us about it so that we can see if we can get a different match that's better for them rather than dropping out of treatment. That's kind of what we do across the board here in our team at Colgate as well. So that's happened a couple times, but not very many.
Well, and one of the ways that we try to create good matches is to have a provider group that's really diverse, so that we can bring in providers of color, providers who specialize in LGBTQ plus care, those kinds of things. And I think especially for some universities, it can be very hard to recruit providers, minority providers, or providers that work with underserved groups. And this is a way that we can all kind of pool our resources and share those specialized providers with multiple schools.
Absolutely. And that ties into some of the overall student feedback here, which compares a little bit to what we're seeing at Colgate, but we're obviously having these students sort of fill out surveys in the moment, and we're also doing NPS surveys on a semesterly basis. We just introduced a flourishing scale as well as part of the patient experience, and 81% of students are saying that Mantra is helping them take care of their mental health. About 2/3 of them are saying that we help them perform better in school, and 70% are saying that we help them stay enrolled in school, which I think is, I think from an administrator's perspective, something that really, really ultimately matters for both the on-the-ground teams and whoever you may choose to partner with. Ultimately, what are the outcomes, both clinical, but also in terms of the academic and engagement outcome for that student. Nora, any other comments you have on that?
Yeah, I was just going to say these are numbers I think we're particularly proud of, because many of the illnesses that we treat disengage students from academic care, separate them from the ability to focus and concentrate and those kinds of things. So, I mean, to have 70% of the students coming in saying that we're helping them stay in school really is satisfying when we take a look at that, I think, as a company. And that really, not to switch into just the economics of it, but that really does pay off when you're talking about what you lose and what the community loses if a student drops out of school.
Absolutely.
And there are a small number of students that we see that we refer and support dropping out of school because that's what they need to do in order to stay safe and well. And so those are students that we try to get them connected well to services so that they can get well and come back.
Absolutely. So maybe going into some of the questions that were asked by some of the group here ahead of time, there was a question about the implementation process. So I'm going to walk through our implementation process a little bit, but Don, feel free to chime in based on your experience working with our partner success team. But depending on the model that we'll deploy, I know that some of you on this call today may have had conversations with our team about a model that is maybe a little bit more comprehensive in the terms of services that we can perform, as opposed to the psychiatry partnership that we have at Colgate. But there's basically two main types of partnerships. Either we limit the referral at the counseling center or at the health center, or we have a model where really all students can access our services directly, and we also collaborate with the clinics on the ground for referrals, and we also collaborate with other sometimes non-clinical referrers and can provide staff education and trainings to be able to help these non-clinical staff refer students into care with Mantra, with our version of our collaboration portal. And so really the step number one is to understand the campus structure, understand your current workflows, the goal for the partnership, and which staff will have access to the collaboration portal. That is, regardless of the sort of student journey that we decide to go for, and regardless of the services that we offer, we'll go through an exploration during the process of outlining the partnership, and once the contract is signed, there is going to be a warm handoff and then another call to be able to make sure we collect these resources, understand what's happening on the ground, and make sure that we can get that into our EHR, so that when our providers are seeing your students, we can contextualize the care experience to that specific campus. And that's something that is very unique to Mantra. Step number two is to really review the training and launch plan with the team, and then finalize a go live date. So there's typically going to be a second meeting where we basically present back the information that we've collected, make sure that we're aligned, and that we decide on a go live date. Typically, depending on the contract, it can be anywhere from 2 to 4 weeks from the moment that the contract actually gets signed. We typically start implementation a little bit before that, assuming that the contract will get signed. And then we typically train after that, the team on how to use the collaboration portal, how to make referrals. So I'll kind of show this in a second. And then after that, typically it's go live date. So, as I said, pretty pretty quick and seamless process in how we've sort of designed it. As I said, of course, if you are a campus that is offering, direct sign up for students as well, there's going to be more work we'll probably do on, how to market the program directly to students as well, how to set up a sign up flow inside of your patient portal, your student portal or your intranet, for example, put together a press release. All these things will also typically happen, kind of pre-launch with our partner success team. But Dawn, anything you'd like to add to all of this?
No, I think you had it covered. Thanks.
Sounds good. I'm being mindful of time. I'm going to do a very quick demonstration of our collaboration portal, and then I want to make sure we have time at the end because we already had some questions come in. So I'm now logging in as a therapist at Montreal University, and let's refer a student into care. Yeah, you would typically go here, and since I'm sitting across one of our team members named Eric Mate, I'll use his name as a student and give him a slightly different birth date, but let's assume he's a student to care, and you can make a referral depending obviously on the care that is being provided. As Dawn said earlier, we have the ability to structure our partnerships to offer therapy and or psychiatry. And so let's assume we're making a referral to psychiatry here. You can use the email address of the student. We also have the ability to do single sign-on and the student's phone number in case of emergency or follow-ups. This is also important to send reminders before appointments, and the student's residential state. In this case, let's call it New York.
And what
And
we put there is where the student is in school at the time, because some practitioners can't practice across state lines. So you want to make sure that you do it. For me, it would be in New York.
yep, that's correct. And since recently I've had the ability to build our provider group across 50 states, so I know that for some people on the call, this is of interest. I'm Arthur Senthal, the LCSW on campus that's referring, so I'll put myself as part of the campus team for this student. And then you can decide what level of information you want. As a referrer, you can choose to either collaborate or monitor. Let's say here, I'm someone that is a therapist. I want to continue seeing the student on campus, and I want to collaborate with the psychiatric provider at Mantra virtually. And so I will have access to things like provider messaging, which I'll show, which enable a better level of collaboration. If it's, for example, a therapy to therapy referral and there's no collaboration necessarily needed, sometimes our schools will just choose to have access to monitoring and not get bogged down by a certain level of information that they don't necessarily need. So that's quite flexible. You hit submit, and this is really all you have to do to be able to refer a student into care. So this can take you up to let's say 2 minutes, and you can do this while you're sitting across the room with the student. And then there's 2 other things that you can do. Let's say you're still sitting across the room. Eric is still here with me. I can click here on scheduling an appointment, and then this will give you availability into the schedules of our providers licensed in your state. And so you'll be able to look at an array of providers that are here, screened by the times that they have available, their clinical specialties. If we click into the profile here of Dr. Brooks, you'll be able to see that he's got an array of different specialties, including racial trauma, which may be of interest to the student that is sitting across the room from you. And this is a provider that's got a lot of licenses, but a lot of the time that's not necessarily the case. This is just a demo account. But that gives you an idea of how the referral process works. So we want to refer to Dr. Brooks, which is 2 p.m., book an appointment, and that's it. That time has now been saved for Eric and Dr. Brooks. Eric will receive an email, an SMS notification, and then before the appointment, which is set to happen on November 11th, we'll continue to get reminders to make sure they show up to the appointment, which is a big metric that we track. Let's look at a student now that has been under care for several months and has been seeing a provider with Mantra. And the first thing here that pops up is really these clinical scales that we track. So we'll be looking at depression, anxiety scales, and we have a 100% compliance rate on these scales. The secret for that is that students cannot actually log into their follow-up appointments unless they complete those scales prior to the appointment. This really helps inform the care that we provided in a measurement-based way. And then what you'll be able to see here as well is just who is going to be the collaborators on the Mantra side, on the campus side, what diagnoses have been established for the student, what medications were prescribed. So this is easy to access. What wellness goals Dawn was touching on, our providers' philosophy, especially in psychiatric care, around, not necessarily pushing medications. I think we stay very true to that philosophy, and that includes having wellness goals even when we're working on medication management with a patient for psychiatry. And then really a whole timeline of what's been happening with this student. And so you can dig into the notes. Those notes, if you have titanium, very soon will be directly pushed into your EMR as well. And we're talking to other EHR companies as well. So this is a quite exciting update on the product side. You're able to look into the latest assessments that a student has taken and dig deeper into those. Full list of appointments in the history for that specific student. Talking about our high-risk student sort of approach. That is something that you're able to collaborate on with us by having a student safety plan that will be accessible for the student on their phone. So we're really the only product in the market that actually has a digital safety plan, as part of the patient experience, which is quite unique and speaks to our level of rigor when it comes to safety protocols. And then lastly, this is again a student where Arthur, the on-campus collaborator, has chosen to be a collaborator for the student. And this is really a back and forth team messaging, like you would see on platforms like Slack and others, where the care team can really talk about what's been happening with Sam and can collaborate in the care of the student, which is very unique to Mantra. So that's a little bit about the collaboration experience, and then finally, as a team on the ground, and usually as an administrator, and I'll preface that these numbers are not typically what we have. There's a bit of an update we need to do on our demo environment, but you're able to see at all times current active students. Our referral completion rate, I think for last year, was 88% across our book of partners. So this is from the moment a student is referred to actually attending the first appointment. And then I will reassure you that referral to first visit is not 170 days, but typically, as Nora said, within a week. So this is again a demo environment. And then we'll track things like visit attendance, what happens within the appointments that are booked, how satisfied are students, we ask at the end of each appointment, which students are presenting with, a level of risk that is high or imminent. So this is something that you can see on this list that are suicidal or have an active safety plan. So you can think of this as like your cockpit as a counseling director to understand, which students might require the most attention, activity from the team, and then a diagnosis breakdown, which is quite neat for end of semester reportings, being able to just kind of dive in there and looking at the presenting issues that we're seeing within your patient population.
May I just jump in for 1 minute and say for the patient monitoring as well, those are not patients that we expect you to be responsible for. It's just for your ability to understand who might walk into your crisis center on campus and things like that. We review that list quite regularly, and our providers also have collaborators, either physicians in the case of nurse practitioners, or experienced PhD level or experienced college mental health folks who look over this list and make sure that those students are being followed correctly, they're not falling out of care, those types of things. So just to reassure that even though you have access to kind of seeing what's going on, we truly are taking care of these students and kind of owning them.
Absolutely. So I'll stop sharing now, and we can walk through the list of questions that we have here. I want to make sure that we cover those. Thank you so much, Nora, for the additional color here. So I'll start from the top, and thanks, Farah, for narrowing down the list. And first one is, can you speak to how information flows back and forth through the dashboard, EMRs, and then I'm supposing this is patient consent agreements. So we, first of all, have and get patient consent through the sign up flow where students create their accounts, but there's also a lot of work that we do on the ground during implementation, during training, so that the expectation can be set to the student that this information will flow back into the relevant clinicians. It's very important to make sure that it's clear that this is not information that's going to be accessible across any single staff member at the university. This is really clinical collaboration, and so there's a lot of guardrails around who can access this information. And as I said, we will be going live in this month or next month with our titanium integration, which is really exciting. There's a question about whether or not Point and Click is another company. They're definitely on our list alongside Medicat and others. And so, yes, you are on Medicat. That's right. So we are in conversations, and we'll be working through the list of EMRs. There's not that many in the world of college mental health, so it's really just going to be a roadmap thing. But it's one of our biggest investments on the product and engineering side over the course of next year. So very excited for that progress. There's a question about how we hire providers. Nora, do you want to take that one?
Absolutely. So, I think we do actually pretty deep dive in our hiring, because obviously we need to start with providers that are pretty competent in this sphere. I think the first thing that we do is we look at their clinical readiness at their experience level, and make sure that, first of all, they're of a level, if they're a therapist, that they don't need day-to-day supervision, that they've practiced long enough independently to be able to practice. We still do supervise, we still do advise, but we want folks that are relatively experienced and have some experience in college mental health specifically. We look for providers who have diverse backgrounds and interview some on their understanding of how to work with students from different backgrounds as well. I think that's really important, that we can have culturally competent providers across the board. And then we do background checks and those sorts of general things to make sure that they are going to match our level of care. We do look for folks also with specific experience in college mental health. We can't always find it in every state, but we look for someone who at least has enough depth of background that we feel comfortable bringing them into our program. And then we do a pretty deep dive in clinical training and oversight as well, so that we start with clinicians who have the mentality that we are looking for in terms of wanting to be evidence-based, in terms of wanting to collaborate, and in terms of being interactive and collaborative with their supervisors and with other experts in the field, to make sure that they're open and receptive to that kind of interactive care. And then from there, we try to train them in our particular model, and making sure that their charting is very thorough and those sorts of things going forward. I think there was a question as well about, are they part-time or full-time? And we have both. So we have a number of full-time providers, and we have a number of part-time providers, and that's really so that we can not only recruit diverse providers who may, we have folks who already work in college counseling centers that then come and do part of their time with us, or work in community mental health centers and do part of their time with us. And then we have others that work with us exclusively. Either way, we're still overseeing their clinical quality, and we're, excuse me, sorry, I've got a bad cold. We're keeping an eye on those trainings.
this is how committed we are to the trainings at Mantra. Thanks, Nora. Yes, and I will add as Nora's gathering her breath that we do have a full-time team of clinical recruiters at Mantra to really support our provider group and work with the team there to make sure that based on the campuses that we work with, trying to understand where do we need to hire these providers, as Nora said, the clinical specialties, et cetera. So last question I think that we had on this list, maybe I'll pause and see if there was any other follow-up questions to what Nora just said or to my response to EHR integrations. Nope. Okay. So I think the last piece to cover here was how does our pricing work? And there's really two models at this point that we've standardized on. One model is really akin to what we're doing here with Colgate, where, as Dawn said earlier, we really look at a capacity expansion model is what we call it, and we work with a counseling center, we work with a health center to understand where are your current gaps in capacity when it comes to therapy, psychiatry, or both. And typically this kind of partnership is one where we'll take a very collaborative approach, and we're here to solve a problem where there's really a gap in capacity on campus. It's become really hard to hire on campus, and so Mantra comes in as this virtual layer that allows you to expand virtually your ability to serve the wait lists that you have. And so for that model, we basically have a certain amount of hours per week that we will serve for the school. Typically, these hours are reduced during breaks so that we make sure to optimize for how much is actually needed over time. And so we have a 85% of the pricing, which will be on the certain amount of hours per week multiplied by that hourly rate for both therapy and psychiatry. And then there's a 10% software license and support fee that will scale based on how many hours we're doing, and then a 5% implementation fee. And so again, this model is really designed so that you're only paying for what you actually need. And this is great for schools and counseling centers that come to us with a very specific need around capacity. They know exactly how much they want or they might need in the future during the year, and then we work with them to basically scale with that capacity over time. The model that we're launching soon, and this speaks to one question that just came in about whether or not we offer self-help content, is that next year we'll be introducing a new model for institutions that may be well staffed at their counseling center, but want to offer something that goes beyond that and that is accessible to students online, that covers a whole variety of spectrums. There's no specific gap at the counseling center per se, but there's this willingness to offer something additional to students that is directly accessible online. And so in this model, we've very much taken this as a population health model where we've basically built a system where students are able to be triaged to the right level of care, whether that ranges from self-help guided programs, and we've hired Dr. Carla Chagani to build the first DBT program for college students that is digital and self-guided. So this is something that we'll be piloting with a few of our schools already in the spring that we're really excited about, that students will be able to access directly. And then from there, we're building a layer to effectively allow students to access care for both therapy and psychiatry if needed. And we have a partnership with a crisis line called DD Hirsch if the school requires a crisis line as well. So we can really offer an end-to-end solution for the campus, which will typically be priced on a per student per year. So this is a little bit different than the capacity expansion. Students can sign up directly. We still collaborate with the on-the-ground teams, but this is much more for schools that just want this kind of like end-to-end offering, which is a bit closer to what you may have seen in the market already. And then there's a question about, do we have existing models to help us decide how many hours we might need? So again, this is really where we'll sit down with you. We'll have the conversation on, are you in a place where you have a current gap at the counseling center or your health center, yes or no? If we feel like there's a current wait list, this is typically the first thing that we'll look at. So what's the time to care at the counseling center on the ground? And if the time to care is in the 3 weeks, 4 weeks, 5 weeks, this is typically when we can come in and help you actually figure out how many hours will help you actually cut down that wait list. And then another way to think about it is, well, out of the students that come to you, how many of them are asking for, for weekend appointments, for evening hours? That's another way in which we'll actually look at your current gaps, and we'll build a program where we can define a certain amount of hours, if you're unsure, that fits, your school. If the reason why you can't figure out how many hours is because you're actually very interested in a program that can actually do much more than just therapy and or psychiatry, then we should definitely have a conversation about this population model that we're building, that includes direct sign up, that is just a flat fee for all students. And in that world, there's no need to like overthink how many hours you're trying to do and to flex up. This is much more of a an overall benefit that you want to offer to students that's separate from the counseling center. And so that's something that we're able to have a conversation about as well.
Mm-hmm. Can I add something quickly, Ed? I know we're coming out to the end of our time, but I think one of the things that this really demonstrates for me is something that I love about Mantra, and that is how innovative we've tried to be. I think that college mental health is kind of in crisis, and was when we started this. And so what we're trying to do is really be imaginative about how do we get students to the right level of care? How do we figure out what the right level of care is, and then how do we create something that's evidence-based to support that? We've got other programs that we've been working on with Colgate too that we didn't have time to talk about today, including helping schools diagnose and treat ADHD and kind of guide providers through that process. Having an MD consultant come in for the really difficult cases and being able to provide that kind of level of interaction with schools. In the DBT program that you're mentioning. So we're really trying to listen to our partners and listen to the group of experts that we've put together to try to help build this and figure out, how do we not only help with capacity expansion, but how do we actually become part of the solution and that we need to have nationally in terms of what's going on with college mental health and access to care?
And with that, I think we're at the 2 p.m. mark. Looks like there's no other questions, so we'll be following up individually with a recording and any follow-up questions that you may have. But I wanted to thank everybody for coming in today. Dawn, thank you so much for doing this. You guys have been an amazing partner. We're very excited about the future together. So leave the time here to say that. And yeah, Nora, thanks to you as well for your time.
Thanks, everybody. If there's anyone on the call that does want to have any kind of offline follow-up conversation, just send me an email and we'll find a time to connect. So thank you.
Yeah.
Thank you, Dawn, and thank you, Nora.